Hello again. I'm Dr. James Amos, consulting psychiatrist for University Hospital in Iowa City, Iowa. And this is a Dirty Dozen on suicide risk assessment. And this presentation will be available on my blog site at The Practical Psychosomaticist as usual. You can find that at jajsamos.wordpress.com. And the presentation will include slide annotations as usual, some remarks, and a quiz. And I would like to start with a short reading selection or two from the book that Dr. Robert G. Robinson and I co-edited, the Psychosomatic Medicine, An Introduction to Consultation Liaison Psychiatry, with many contributors. And the chapter that I wrote on suicide risk assessment starts in this way. It has been said that there are only two kinds of psychiatrists: those who have had patients commit suicide and those who will. No task is more difficult for the psychiatrist or any other healthcare professional than suicide risk assessment. No treatment outcome is more devastating than suicide. Academic departments and private practice organizations are in many cases ill-prepared to help their members or the families who are left behind cope with the devastating aftermath. Shock, guilt and shame, isolation, grief, dissociation, crises of faith about psychotherapy and other treatments, and grandiosity associated with the suicide of a loved one. Another short selection about systematic suicide risk assessment, which is what we'll be going over today. The components of the suicide risk assessment ideally should be easy to remember, be based on empirically demonstrable essential features, be readily transferable from emergency room or intensive care unit to consulting room, foster a therapeutic alliance, facilitate the gathering of valid information, and guide treatment decisions. The most recent issue of Psychiatric Annals has devoted the entire issue to suicide. This is the March 2012 edition, and it is devoted to the topic of suicide. Identifying its causal mechanisms can lead to more effective interventions, and you should probably consider taking a look at that. I'm going to follow along with the slides, and the slide 3, as usual, is a slide about statistics associated with suicide. Suicide rates roughly run between 10 to 20 per 100,000. There are approximately 10 to 15 million suicide attempts annually, and 1 million people die annually worldwide of suicide. 95% of them are linked to psychiatric illness, most of them treatable. It's also occurs in medical illness as well. The default management would be to hospitalize patients who have suicide ideation with plan and intent. Slide 4 has to do with the psychiatric disorders, some of them, which are associated with suicide. First and foremost, major depression, marked by hopelessness, severe anxiety and agitation, and things like global insomnia. Psychosis, including command hallucinations, and hyperreligiosity sometimes can be associated with suicide as well, and severe personality disorders, which are enduring and chronic maladaptive ways of interacting with other people and tolerating distress, also can be associated with suicide. Alcohol use disorders and other drug abuse and drug dependence problems can be associated with suicide as well, and tend to raise the risk for suicide. Slide 5 is about suicide risk assessment processes themselves, and the usual model is to elicit suicide ideation, which means you have to ask, Merely asking someone about suicide ideation doesn't put the idea, plan, and intent into their heads. You want to uncover risk factors for suicide, including the ones that are individual and idiosyncratic. You want to uncover symptoms and signs of modifiable risk factors such as psychiatric disorders, including major depression and anxiety disorders. And you want to talk about situational stressors or personal problems that are driving the person toward considering or thinking about suicide in a black tunnel sort of way, ruling out all other coping alternatives. You want to identify protective factors as well. Some factors that are thought to be protective, but not always, are for young women, small children, or infants in the home. Spirituality or religious faith can be protective at times, and you want to formulate an impression and a plan for intervention and document that. Slide 6 goes further with suicide risk assessment and brings us to specific ways of formulating them and making sure that we document what we do. You want to detect predisposing factors such as psychiatric illness, as I've already mentioned. You want to detect potentiating factors such as stresses within the social support system. And there's an excellent paper written by a colleague of mine and two other co-authors, Dr. Jess Fedorowicz and co-authors Dr. Kaiser Weldon, who currently at the time that that paper was written was a resident in our psychiatry residency program, and Dr. Burgess, who is with the Department of Family Medicine. There's a link to that paper on my website. The title of the paper is Determining Suicide Risk. Hint, a screen is not enough. And it's in the Journal of Family Practice. Conducting a specific suicide inquiry will help determine the level of intervention, and of course the default is hospitalization. The other alternative is to discharge the patient from the emergency room or the clinic with a safety plan. And that's not the same thing as a no self-harm or no suicide contract, otherwise known as suicide prevention contracting, or SPC. Those do not prevent suicide and ought to be discouraged. And of course, lastly, you want to document the assessment carefully. Slide 7 are about the pitfalls in interview techniques, which clinicians ought to be aware of. It's sometimes very difficult to get a valid history from someone who is bent on killing himself or herself. Sadly, often patients who are resolved to kill themselves see the mental health care provider who's trying to help them as the enemy. 25% of patients at risk for suicide don't tell clinicians, and often those patients see a non-psychiatric medical provider, such as a family physician, just before they kill themselves. The interview is probably never straightforward. Clues to invalid patient reports include, but are not limited to, agitation and anxiety during the interview, a tendency for the patient to break eye contact when talking about emotional issues, and crying while professing safety at the same time. You must raise your own level of skepticism and concern about signals like these, because they're warning signs. The next slide is slide 8, which is about suicide risk assessment models. There's no standardized way of conducting suicide risk assessments. But there are many models out there that are probably helpful to remind clinicians about what they should be asking and how they should be asking. Suicide assessment 5-step evaluation and triage, otherwise known as SAFE-T, is available, and there is a pocket card that you can view on my blog site. You want to see the Fowler and colleagues reference in the reference list at the end of the presentation. And there's a link also to where you can download the pocket card. The other model is the chronological assessment of suicide events, otherwise known as CASE, developed by Sean Shea. There's a reference for that as well. The schematic of that is to ask about presenting suicide ideation and behaviors, move to recent suicide ideation and behavior over the preceding 8 weeks, moving then to past suicide ideation and behaviors, and then swinging back to immediate suicide ideation and future suicide plans and intent. There's a link to that process as well in the presentation on my blog site. Slide 9 is a slide about advice for family care physicians about conducting practical suicide risk assessment in busy practices. The hierarchy of suicide assessment includes asking about thoughts of death, suicide ideation next, plans for suicide, means that might be available such as firearms, and intent. And that's the McDowell, Lineberry, and Bostwick reference. The ability to recognize and treat severe anxiety and agitation are critical because severe anxiety and agitation often drives hopelessness and the intent to kill oneself. And the McDowell paper also recommends the SAFE-T model. Implementing simple things in the practical office management sense would be having available crisis phone numbers, such as the National Suicide Prevention Lifeline number, 1-800-273-TALK, or 1-800-273-8255. Suicide safety plans can be designed. You can use pre-printed forms, or you can work on them with the person in your office or in the emergency room in a handmade kind of way, handwritten. Always consider calling for psychiatric consultation if it's available. Psychiatrists are always willing and able to collaborate. Slide 10. Evaluating competency in conducting suicide risk assessment, I think, is a very important way to help clinicians learn at any level of training, faculty to resident in a training program. So there happens to be a instrument called the Competency Assessment Instrument for Suicide Risk Assessment, or the CAIS Risk Assessment Scale, or tool rather. And for that you want to look at the Hung and colleagues paper in the list of references, and you can contact the authors of that paper for the full instrument. The items include interview components such as obtaining rapport, history taking, getting collateral information, eliciting suicide ideation with risk factors, case formulation, estimating the risk and the time frame for the risk, as well as treatment planning and documentation. And the items are rated on a scale from either number 1, task not done, all the way up to 8, which would be advanced. And of course, the last 2 slides, 11 and 12, in this presentation are references and resources. I hope that you'll contact me with comments, questions, or suggestions for improving our awareness of the need for suicide risk assessment, whether or not opinions exist regarding the possibility of preventing suicide. Even if there are those who engage in a debate about clinicians never being able to prevent suicide by doing suicide risk assessments in the psychiatry clinic or in the emergency room, that doesn't mean we should stop trying. Please contact me with any questions or comments that you have. Thanks very much.